Thank you so much for asking me to come and speak. I think there's so much excitement in the heart failure community about all the new treatments that we have, and mitral interventions certainly play a role. I have no disclosures. So I think we've been over this already, but the biggest question that I ask myself when I'm seeing a patient with mitral regurgitation is the problem the valve or the ventricle. And in my clinic as a heart failure doc, it's usually the latter. The problem is usually the ventricle. And we call that secondary mitral regurgitation. And the left ventricular dysfunction and dilatation results in leaflet tethering, dilatation of the mitral annulus, and this causes incomplete coaptation of the mitral valve. We've all seen those TEs and TTEs where the leaflets aren't even touching and there's just torrential MR. If left untreated, regardless of the cause, mitral regurgitation can rapidly lead to increased morbidity and mortality. And I usually try to stay away from a circle graph, but I think in this case it's warranted. Truly, the worsening mitral regurgitation leads to worsening heart failure, which leads to worsening mitral regurgitation, et cetera, et cetera. So this needs to be treated. It's very common in our patients with heart failure. 1 in 5 heart failure patients have moderate to severe secondary mitral regurgitation. And unfortunately, most of these folks are left untreated. I think we're so used to seeing this on echo in our patients with heart failure, and we say, oh, they need more diuresis, increase their Lasix in clinic, and we'll recheck an echo in 6 months. That's sort of been standard practice. But we know that if we don't do anything, 72% of these folks with grade 3 or higher mitral regurgitation will either have a hospitalization or a death within 2 years. So we need to have be a little bit faster when we reevaluate these patients and the way that we manage them. Why is mortality so high? Well, I think Dr. Cole's going to speak a little bit to this, in terms of the impact of the ventricle, and it's kind of a chicken or the egg sort of idea. Is this truly advanced heart failure? Is the mitral regurgitation more of a harbinger of worsening heart failure, or is this a valvular issue that, if left untreated, will lead to worsening heart failure? The signs and symptoms certainly of worsening mitral regurgitation are very similar to heart failure and can be ambiguous. Sometimes I feel like I'm running a fatigue clinic and I'm the fatigue detective trying to figure out, why is someone tired? It's at their heart failure, their advancing age, their valve disease, sleep apnea, et cetera. So sort of teasing out all of these, different competing issues can be challenging. The 2020 guidelines really emphasized the role of the multidisciplinary treatment for valvular disease. And this really brought a lot of the heart failure docs into the mitral regurgitation space. And I think this is really important. In fact, the updated guidelines give it a class 1 recommendation to have a heart failure cardiologist or an expert in GDMT or guideline-directed medical therapy for heart failure involved, and in fact, the clinician in charge of directing care for optimal GDMT for these patients. So what do we mean by GDMT for mitral regurgitation? Well, this could be medications, device-based, arrhythmia-based treatment. Basically, we want to do anything and everything we can to optimize the patient. The cornerstone of treatment is diuresis. We really have to decongest these patients. Some of these patients have been walking around for years and years, with 20, 30 pounds of fluid, and they've just gotten so used to it. They may need to be in the hospital for a week or even 2 weeks to get all the fluid off, but it's imperative that we decongest these patients, to a euvolemic state. We also want to improve LV relaxation, and if this is a HFpEF patient or somebody with HOCM, as we'll hear later, that may be a calcium channel blocker, or if it's a HFrEF patient, we may want to employ our traditional 4-pillar GDMT as was touched on earlier. I also want to underscore the importance of maintaining sinus rhythm. It's so important for these patients that we get them in rhythm. I think atrial contraction can play a large role in severity of mitral regurgitation, and to send somebody for an intervention before restoring sinus rhythm, I think, is premature. So this is my favorite topic for those of you who are employed at Piedmont. Hopefully you've watched our GDMT videos and you're already experts. But the new mantra in the heart failure community is the 4-pillar strategy. And by 4 pillars, we mean the ACE-ARB-ARNI, MRA, beta blocker, and SGLT2 inhibitors. And we advocate for a rapid sequencing protocol for initiating GDMT, which basically means to start everything all at once, right away, and titrate it up as quickly as possible. And this really improves and dramatically reduced heart failure hospitalizations. It decreases mortality. Many of these medications have benefit within the first 2 to 4 weeks. So any delay can result in unnecessary death, hospitalization, and morbidity. Patients feel better. Their ejection fraction can improve more rapidly. And this also leads to improved use, adherence, and helps us to stomp out what we call inertia, amongst providers when it comes to initiating GDMT and heart failure. So what does this look like? Like I mentioned, we basically just want to start everything all at once at a low dose. Most of these medications shouldn't drop blood pressure that much. Certainly we do have to take care of the hypotensive or maybe our older adults, or other clinical concerns. And then we continue to titrate initially the beta blocker, knowing that that medication has the greatest chance to remodel and improve heart function. By 1 month, really 2 to 4 weeks, we should be, at optimum doses almost, and continue titrating to the highest tolerated dose. What I tell my patients is, if you're a little dizzy when you stand up, that's okay. If you feel like you're going to pass out, that's too much. But we wouldn't stop chemotherapy for mild side effects. And we shouldn't stop GDMT.
And Catherine, are you doing this through virtual visits? Are you doing it through in-person visits every time? Because that's hard for those patients to come to your office every 2 weeks.
Great question. I typically, if it's a patient I think can handle it, I'll outline exactly what I want them to do at home. Otherwise, I'll have them come back for an NP visit or a virtual visit, or we actually started a pharmacy titration clinic to help with some of the more challenging titration issues. GDMT can successfully treat MR. I think, in this study, 40% of patients who are initially described as having moderate to severe dropped to mild to moderate. I know in the COAP trial, a third of the patients originally targeted actually no longer qualified because after initiation of GDMT, they improved. And GDMT, along with mitral interventions, can have a dramatic effect on our patients. If you look at the y-axis here, that's decrease in mortality, which is tremendous. Imagine if this was, breast cancer treatment. We would leave no stone unturned, right? We would, employ every medication, every surgery, every treatment, and we should do the same for our heart failure patients. I know when the COAP trial came out, I almost fell out of my chair when I saw the impact it had in terms of mortality, and it remains a tremendous treatment for our patients who have failed GDMT and need intervention. In fact, if you look at the number needed to treat in the COAP trial, versus some of our GDMT, the effect is remarkable. So the 2022 guidelines for the management of heart failure have strengthened recommendations for secondary MR patients, including interventions like the MitraClip and other interventions that I'm sure we've heard about and will hear about. And these updates underscore the importance of timely echo screening and rapid sequencing of GDMT optimization and evaluation of these patients, frequently and very quickly. So I want to end with a call to action. How do we change the course for our patients with heart failure who have secondary mitral regurgitation? I want to empower everybody in the audience, not to just repeat an echo in 6 months, but to really push these patients, their decongestion, GDMT, rhythm control, anything and everything that we can do, and to evaluate them and reevaluate them quickly for a mitral intervention as appropriate. All right. And thank you, Julie, for putting my slides together in this inspirational quote. All right. Thank you.
Great. Thanks so much, Catherine.